Okay, so this is a talk on the topic of Anisocoria. And this is a talk that I meant to record very early in the morning at my house in quiet. And of course, I have two little people sitting beside me who decided to wake up a little bit early. So there might be some questions or interruptions in the middle as they eat their breakfast. All right, so you're working one day at the hospital and go to bring in the next patient, and a very familiar looking face is waiting out in the waiting room. It's David Duchovny, and you bring him in and he explains to you that a lot of people have been bringing to his attention the fact that his pupils seem to have different sizes, and he was concerned about it and came to the hospital to be seen. So when you, in fact, look a little more closely, you recognize that the right side pupil is larger than the left side pupil. And here we see, if we outline the size of the pupils, that indeed the right side is larger. And the question becomes, which side is the pathological side? Is the right side the problem because it's too large, or is the left side the problem because it's too small?
Papa.
Yes?
I'm itchy.
You're a little itchy?
Yeah.
Okay. Does that feel better? Okay, great. All right, so we're just going to continue with the lecture here, okay?
I'm itchy, Papa.
You're also itchy? Okay, there you go. Okay, so again, which side is the problematic side? So when we approach our differential diagnosis, we can think about structure and function. So the first thing that we can do with a patient who comes in like this is take a look at them at the slit lamp, because okay, I'm fine, guys. You guys paying attention?
Yeah.
Okay, good. All right. So we can have them look at the slit lamp because we might see that the problem, the reason, for example, that the pupil is too large might be some sort of anatomical problem with the iris. So, for example, if the patient had a history of trauma, if they were struck in the eye at an earlier time, then the sphincters that constrict the iris might be a little bit weak, causing the pupil to bump. Okay, just a second. Let's pour milk here. There you go. And therefore the pupil size might be a little too large. Another possibility is that they have a history of iritis, which can be obtained by history or at the slit lamp as well. You might see cells and other features such as posterior synechii. And this would obviously explain why, if this happened in one eye, why the size of the pupil would be different than the other eye. If, however, by asking the patient the history questions and by examining with the slit lamp, there's no reason why the iris structure should be different in that eye, then we have to think about the question of function. And to address that, we ask the question, what nervous system controls the size of the pupil? And the answer is the autonomic system. And how does that work? So we have the sympathetic system that causes the pupils to become dilated. For example, right now, if I made a loud noise and scared someone in the audience, I'm not going to do that to one of the kids, then we would obviously expect that the pupils dilate as part of the sympathetic, the adrenaline-like drive that happens. Conversely, the parasympathetic system causes the pupil size to constrict. So when we come out and find ourselves in very bright lights, pupils become smaller, and that's because of the activity of the parasympathetic system. So that in dark, we're relying on our sympathetic system to dilate our eyes. It makes sense that when we're in the dark and we're scared, that the sympathetic system dilates the eyes, and then you're both cold. Okay, I'm going to get you something to warm you up with, and we'll just pause this for a second. Okay, we're back and we're all a little bit warmer. So let's move on. So if we think about what could be going wrong functionally, then if the problematic side is the one that's too small, in the case of our patient, this would be the left eye, then the autonomic issue would be that the sympathetic drive is less than the parasympathetic drive. And that could either scientifically mean that either the sympathetic drive is too small or the parasympathetic drive is too large. We don't really have situations where we have in one eye on one side increased parasympathetic drive. We certainly do have a situation where we have impairment of the sympathetic tone, and this is called Horner syndrome. If the other eye is the pathological side, where the pupil is too large, then this would correspond to a situation where the sympathetic drive outweighs the parasympathetic drive. Once again, we don't have a pathological situation of having impaired heightened sympathetic drive to an eye. What we do have is a situation where we have decreased parasympathetic tone to an eye. And in terms of conditions that go along with that, the two that we would need to think about are third nerve palsy, something that's less commonly known, called an Adie's tonic pupil. So in terms of a third nerve palsy, if we're worried about that, what other features are we going to look for? Well, we'd be looking for a marked ptosis, and we'd be looking for a strabismus. And this should be very apparent. It would be extremely unusual to have a patient that came in who had a third nerve palsy where just the pupil was affected. In fact, it would almost be impossible if we're discussing the case of a awake patient in your clinic. This is something that could happen in an ICU setting, but if this is someone who came to see you off the street and there was no marked ptosis or strabismus, you don't really need to be worried about it being a third nerve palsy. If, on the other hand, we're thinking about a Horner syndrome, once again, we are looking for a ptosis. However, this is a much more subtle ptosis. Why? Because the muscle that's involved here is the Muller's muscle, which is a muscle that elevates the lid, but it only makes a very slight contribution relative to the levator muscle. So the ptosis here is sometimes as minimal as 1 millimeter, and you have to look very carefully for it. The other feature that is sometimes seen in a Horner syndrome, at least in the books you might read about it, beyond seeing a small pupil on meiosis, a ptosis, is an anhidrosis. An anhidrosis means that there's a lack of sweating on that side of the face, and that's because the sympathetic system is responsible for sweating. And again, this probably makes sense when we have someone who's frightened and in danger. In addition to the fact that we expect their pupils to dilate and their heart to be pumping fast, we're not surprised that they will be sweating because of the excessive heat production that will be associated with the response. We're going to speak for a moment about this condition called an Adie tonic pupil. So we know that the pupil constricts in response to parasympathetic drive, and those parasympathetic fibers are coming from the brain to the eye through the third nerve. What happens once these parasympathetic fibers arrive into the orbit is that they exit the third nerve proper to enter a ganglion called a ciliary ganglion. They synapse there, and from that point, the new neuron enters the globe to innervate the pupil and cause it to constrict. And sometimes we have situations where there's benign viral infections in the ciliary ganglion that damage these neurons that are running, these parasympathetic neurons that are running from the ciliary ganglion to the globe. And this causes this condition, at least in one model, of an Hades tonic pupil. So we're talking about here an isolated impairment of the efferent parasympathetic fibers. And because of this impairment, we have a relative increase or a relative decrease in parasympathetic tone, and that leads to a larger pupil, which will now react weakly to light. So we've said that when we're thinking about the problem here, a functional problem, it's likely either a sympathetic problem or a parasympathetic problem. And there's a way that we can assess that in the clinic setting. How can this be differentiated? So the answer is altering the conditions that were of the lighting when we look at the pupils. So it makes sense that if we make the lights very bright in the room, then those conditions, very bright light, is driving the parasympathetic system. And if the problem is that the larger pupil is the one that's the pathological one because it has decreased parasympathetic drive, it makes sense that the anisocoria is going to become much more apparent in bright lights. If, on the other hand, when we dim the lights, we see that the anisocoria is most apparent, then it makes sense that the problem must be the sympathetic system because it's in the dim light that we're testing sympathetic drive, where the sympathetic system is supposed to force the eyes to dilate. And if the anisocoria is very apparent in dim light, then the smaller pupil must, or is presumably the one that has limited sympathetic drive to dilate it in the dark. So again, if the anisocoria is most apparent in dim light, we would suspect a sympathetic system dysfunction and think about a Horner syndrome. Whereas if the anisocoria is most apparent in bright light, we would suspect parasympathetic dysfunction and then think about either a third nerve palsy, and after we've reassured ourselves that in this patient that we're seeing in the clinic at least that there's no strabismus and no ptosis, then we were thinking about an Hades tonic pupil. So we've spoken about the differential diagnosis for anisocoria so far, and there is one other thing to add that we'll discuss shortly. We've said that if the pupil is too large, then we need to think about a third nerve palsy and Hades tonic pupil. If the pupil is too small, we need to think about a Horner syndrome. And the final very important thing that I want to touch on is where it's just right, and the idea of physiologic anisocoria. As we're all aware, if we measure both of our hands, we're going to find that there is some small difference in the measurements, and if we compare any two sides of our body, our two ears, our 2 feet, they're not going to be exactly the same size, and this is also the case with the pupils. So in some people, this is actually a little bit more marked and apparent that there's an anisocoria, and again, there's nothing wrong with them, that's just the way that they were made, and this is physiologic, and this is actually something that we can find in about 20 to 30% of the normal population. So that in the case of Mr. Duchovny, presumably the anisocoria that he has is just a physiologic anisocoria, and as we know, he's functioning very well. Beyond the scope of this lecture is the fact that we can actually assess whether the pupil's truly too small or too large based on parasympathetic or sympathetic dysfunction by treating the eyes with various drops that test the sympathetic and parasympathetic activity. These include drops such as cocaine, for example. One of the rare uses for cocaine still in medicine today. But if, after we've fully assessed the patient, we've checked at the slit lamp, we've checked for sympathetic and parasympathetic dysfunction in bright and dark light and found, for example, that there is no significant difference in bright versus dark light, and we might even check with the various drops to confirm that there's no issue, then we can often just be left with a probability that this is just a physiologic anisocoria, and that again there's nothing wrong with the patient. So this is our approach to a differential diagnosis of anisocoria.